Hello, my name is Leo Alexander. I'm an NIHR Doctoral Research Fellow and Gastroenterology Registrar at Norwich Medical School, University of East Anglia, and the Norfolk and Norwich University Hospital. I'd like to thank the editors of Gastroenterology for inviting me to submit a video abstract for our manuscript entitled Statin Use is Associated with Reduced Risk of the Histologic Subtypes of Esophageal Cancer, a Nested Case Control Analysis. There has been considerable research interest in the potential chemopreventive effects of statins against a number of malignancies, including esophageal cancer. Statins have been shown to inhibit proliferation and promote apoptosis in esophageal adenocarcinoma and squamous cell cancer cell lines. Previous observational studies conducted in general population cohorts have demonstrated inverse associations between statin use and risk of esophageal cancer. However, esophageal cancer was considered a composite endpoint in these studies, and it's important to distinguish the two major histological subtypes, adenocarcinoma and squamous cell carcinoma, as they are two distinct entities. The aim of our epidemiological study was to determine the risk of the histological subtypes of esophageal cancer with prior statin use at a population level. We used the General Practice Research Database to conduct this study. The GPRD was particularly suited to this study as it is the world's largest database of prospective prescription data and follow-up for disease endpoints. At the time of data extraction, 4 million patients were registered with 488 general practices throughout the United Kingdom. We confirmed the histological subtype of esophageal cancer through linking the General Practice Research Database to the National Cancer Registry to identify 581 patients with esophageal adenocarcinoma, 213 with esophagogastric junctional adenocarcinoma, and 332 with esophageal squamous cell carcinoma. Each case was linked with up to 4 controls matched for age, gender, and practice. We conducted nested case control analyses using conditional logistic regression to determine the risk of the histological subtypes with prior statin use. We adjusted for confounders relevant to the etiology of the individual subtypes. Regular statin use was defined as a prescription of any statin for a minimum of 10 months in the year preceding the index date. Regular statin use was significantly inversely associated with risk of esophageal adenocarcinoma, with an odds ratio of 0.58 and with evidence of both a dose and duration response. Regular statin use was inversely associated with esophagogastric junctional adenocarcinomas at high dose use only, equivalent to greater than 40 mg of simvastatin, with an odds ratio of 0.29. Regular statin use was not significantly associated with esophageal squamous cell carcinoma, however between 1 to 4 years of use was, with an odds ratio of 0.51. As with previous epidemiological work, significant inverse associations were demonstrated with NSAID use, with evidence of an additive reduction in risk for concomitant use with statins. In conclusion, we demonstrated inverse associations between statin use and risk of the histological subtypes of esophageal cancer at a population level. Inverse associations were most convincing for esophageal adenocarcinoma and esophagogastric junctional adenocarcinomas. The strong inverse associations with dose and duration responses, together with plausible anti-cancer mechanisms, lend support to a causal association. While we would not advocate chemopreventive statin use at a population level, our data supports the development of randomized controlled trials, possibly in those at high risk. Thank you for listening.